Welcome to Dr. Balga's podcast for the Curious Doc. Today is 15 March 2026. This video is on the JACC State-of-the-Art review printed on 4th March 2026 as recently, titled Critical Care Cardiology Perspective on Managing Acute Emergencies in Patients with Durable Ventricular Assist Devices. The senior author is Dr. Jason Katz, who is one of the giants in critical care cardiology. What is the first step in any LVAD emergency? Ensure the pump is connected to power and running because of loss of power is a reversible cause of instability. What are the main components of a durable LVAD system? The system includes an inflow cannula, pump housing with rotor, outflow graft to the aorta, and a driveline connected to the external controller and power source. Why might LVAD patients have no palpable pulse? Continuous flow pumps generate minimal pulsatility, so radial or femoral pulses may be absent despite adequate circulation. How should blood pressure be measured in LVAD patients? Doppler measurement is preferred and the first sound during cuff deflation approximates mean arterial pressure. What are the key LVAD controller parameters clinicians should review? Pump speed, power consumption, estimated flow, and pulsatility index are the primary parameters used to assess function. What does an increase in pump power suggest? Increased power may indicate pump thrombosis, high flow resistance, or increased blood viscosity. What causes low estimated pump flow in LVAD patients? Common causes include hypovolemia, right heart failure, cardiac tamponade, hypertension, or inflow or outflow obstruction. What clinical conditions reduce LVAD preload and cause low flow alarms? Hypovolemia, right ventricular failure, ventricular arrhythmias, and cardiac tamponade can all reduce preload. Why are LVAD pumps sensitive to preload and afterload? Pump flow depends on pressure differences across the pump, so changes in venous return or arterial pressure affect output. What role does echo play in LVAD emergency? TTE or transthoracic echo evaluates ventricular size, cannula position, right ventricular function, and valvular pathology. What echocardiographic findings suggest excessive LV unloading? LV septal deviation indicates excessive unloading or possible right ventricular overload. What complications should be suspected with elevated inflow cannula Doppler velocity? High inflow velocity may indicate cannula malposition against ventricular wall or septum. How common is right heart failure after LVAD implantation? Chronic right ventricular failure approximately occurs in 5% of HeartMate 3 recipients in clinical trial populations. What are the common causes of acute heart failure in LVAD patients? RV failure, aortic regurgitation, uncontrolled hypertension, cardiac arrhythmias, and device malfunction are the typical causes. Why does aortic regurgitation occur in LVAD patients? Continuous flow reduces aortic valve opening, increases transvalvular gradients leading to leaflet degeneration and aortic regurgitation. How is GI bleeding related to LVAD physiology? Reduced pulsatility contributes to arteriovenous malformations and acquired von Willebrand syndrome leading to bleeding. What's the approximate annual stroke risk in modern LVAD recipients? In the Momentum 3 trial, the annualized stroke rate was about 8%. How common are ventricular arrhythmias in LVAD patients? Up to half of the LVAD recipients may experience ventricular arrhythmias. Are chest compressions safe in LVAD patients with cardiac arrest? Available studies show no confirmed device dislodgement, and compressions should not be delayed when arrest is confirmed. What is the most important immediate assessment in an unresponsive LVAD patient? Confirm the controller has power, listen to the device hum, and review alarms to identify reversible pump-related causes. This is in a nutshell from the JACC State-of-the-Art review. Read this fantastic review for more details and a comprehensive overview on this very important topic. The GI bleeding associated with LVADs reminded me of a letter which I wrote, which I authored in the New England Journal of Medicine way back in 2013 regarding Heidi syndrome. The Heidi syndrome was first described in patients with aortic stenosis. A similar clinical picture has been observed in patients with continuous flow LVADs, including the angiodysplastic bleeding, the acquired von Willebrand factor deficiency, and impaired platelet aggregation. It has been suggested that in LVAD patients with axial flow devices, the narrow pulse pressure is an important modifiable factor associated with clinical picture. And there were studies ongoing to determine whether changing the speed of these devices, consequently making the flow more pulsatile, will decrease the incidence of GI bleeding in such patients. Heidi syndrome was first described by a US physician in 1958, where he described the clinical association between aortic stenosis and GI bleeding. He was practicing in St. Louis, Missouri, primarily as a general internist. His paper was published in JAMA. He described 10 patients with severe aortic stenosis and recurrent GI bleeding. At that time, the mechanism was not known. Decades later, research clarified the syndrome. Aortic stenosis was involved with high shear stress, destruction of high molecular weight von Willebrand factor, and bleeding from intestinal angiodysplasia. This pathophysiology was demonstrated in the 90s by William Warkentin and colleagues. The classic citation for Heidi's was GI bleeding in aortic stenosis, JAMA 1958. So a quick guide to LVAD emergencies. First, confirm device power and controller connection. 2. Listen to the LVAD hum over the precordium. 3. Measure mean arterial pressure using Doppler. 4. Evaluate pump parameters, speed, power, flow, pulsatility index. 5. Perform echo to assess LV size, RV function, and cannula position. 6. Review LVAD alarms and device log files. 7. Evaluate hypovolemia, RV failure, tamponade, arrhythmia, or hypertension. Contact the patient's implant LVAD center immediately. Take a screenshot of this checklist so that you're prepared for LVAD emergencies. This is another checklist which is very similar to the previous one. The key pulse. LVAD patients may have no pulse. Use Doppler to measure mean arterial pressure. First rule, check power connection. Review pump speed, flow, power, and pulsatility index. Echo guides diagnosis. And finally, chest compressions are safe when cardiac arrest occurs. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.